Ever been handed a prescription or maybe just looked at the back of an over-the-counter medicine box and felt like, well, like there's this whole secret world of activity happening inside you that you just don't quite get?
Oh, absolutely. Like, how does this little pill actually know where it's supposed to go and what it's supposed to do in it?
Exactly. Well, today we're diving deep. We're aiming to pull back that curtain. We're not just going for the basics here. The goal is to really build a foundational mastery of how drugs interact with our bodies.
Mm-hmm.
Forget those surface level explanations. By the end of this, hopefully you'll be thinking about this stuff like someone who's, really immersed in the field.
That's the plan.
Yeah.
Yeah, today's deep dive is laser focused on pharmacokinetics.
Right.
And you can think of pharmacokinetics as really understanding the entire journey a drug takes inside the body. Our mission here is to get beyond just simple definitions. We want to really understand the principles that govern this journey.
The whole trip.
The whole trip, from the moment it gets into your system until the moment it leaves. So we're talking about absorption, how it gets in, distribution, where it goes once it's inside, metabolism, how your body changes it, and finally, elimination, how you get rid of it.
ADME. Absorption, distribution, metabolism, elimination.
ADME. Those are the 4 cornerstones. And grasping these is absolutely key, not just for understanding how medicines work, but also, why side effects happen or how different drugs might interact with each other. We're really aiming for a level of comprehension that lets you navigate this whole complex area with real expertise.
And to build that expertise, we're going straight to the source. We're using excerpts from GOODMAN and GILMAN's The Pharmacological Basis of Therapeutics.
The gold standard.
Pretty much, yeah. The pharmacology textbook. So, the foundation we're building on is solid, authoritative stuff.
Yes, all right.
Okay, let's jump in. The very first hurdle, right? For any drug getting into the body, it has to cross barriers. It's not like our system just rolls out the welcome mat for any foreign molecule.
Absolutely not. Think of your body as this highly selective, highly protected environment. For a drug to do anything useful, its therapeutic effect, it has to navigate a series of these barriers to reach its target.
And that's where ADME comes in right away.
Right at the beginning. These ADME processes are fundamental to that whole endeavor, how your body handles the drug at each of these stages, absorption, distribution, metabolism, elimination, that dramatically influences whether the treatment works. And it's also the root cause of adverse reactions or, drug interactions.
Okay, so the drug manages to get in somehow, but it doesn't just teleport to where it needs to go. There's movement involved. And it sounds like cell membranes, the walls of our cells, are the big obstacles. Or maybe gateways?
Gateways and obstacles, yeah, both. A drug's ability to get across cell membranes is absolutely essential for its whole journey. And several key properties of the drug itself dictate how easily it can move.
Like what kind of property?
Well, its size, molecular weight, bigger molecules generally have a tougher time. Its specific structure matters too, how it's shaped. Then, maybe surprisingly, whether it carries an electrical charge, we call that the degree of ionization. That's really important.
Charge matters, huh?
Big time. And also its lipid solubility, basically, how well it dissolves in fats or oils compared to water, especially comparing the ionized charged form versus the non-ionized uncharged form.
Okay, so oily stuff gets through easier.
Generally, yes.
Yeah.
And finally, how much the drug likes to stick to proteins floating around in your blood or in your tissues. That binding can affect its movement too. Essentially, only the unbound, free drug is typically able to move across these membrane barriers.
Size and oiliness, those make sense. Smaller, oil-loving things slip through. But ionization, the charge, that sounds trickier. And why does binding to proteins matter so much?
We'll definitely unpack ionization in a bit. It's fascinating and critical. But first, let's picture that main barrier, the plasma membrane itself. Imagine like a sandwich, a double layer, a bilayer of these special molecules called amphipathic lipids.
Amphipathic, meaning dual nature.
Exactly. One end loves water, hydrophilic. The other end hates water, loves fat, hydrophobic.
Yeah.
In the membrane, they line up with the hydrophobic tails pointing inwards, creating this oily, greasy core. And the hydrophilic heads face outwards, towards the watery environment inside and outside the cell.
Okay, like a microscopic oil slick sandwich.
Sort of. And this setup gives the membrane some fluidity, some flexibility. It also gives it high electrical resistance and makes it, crucially, relatively impermeable to polar water-soluble molecules, especially charged ones. So if a drug is very water-soluble or carries a charge, getting through that oily middle part is tough.
Right, that oily core explains why lipid solubility is key. But it's not just fat, is it? You mentioned proteins embedded in there. What are they doing?
The proteins. They're the real workhorses. They do tons of different jobs. Some are structural anchors holding things together. Others are receptors like docking stations where drugs bind to trigger a response inside the cell. Then you have ion channels, which are basically selective beats controlling the flow of charged ions like sodium, potassium. And really important for us, there are transporter proteins. These guys actively or passively help move specific molecules, including many drugs, across the membrane.
So they can help drugs get across.
They can. Or sometimes they pump them back out. And many of these membrane proteins are themselves the specific targets that drugs are designed to hit. It's also worth knowing the membrane isn't just a uniform sheet. It has organized little patches called microdomains, things like lipid rafts rich in specific fats like sphingolipids and cholesterol. There's scaffolding inside for support, even little pockets called caveoli. It's a really complex, organized structure.
Wow, okay, so definitely not just a simple oily layer. It's this dynamic, functional thing with all these specific jobs. So how do drugs actually make it across this barrier then? You mentioned passive diffusion and carrier-mediated transport. Let's start with passive diffusion. You said that's the main way.
Passive diffusion is definitely the dominant mechanism for most drugs. It's really just basic physics driven by, the tendency for things to spread out, moving from an area of high concentration to an area of low concentration until things are even.
Like perfume spreading in a room.
Exactly like that. Drug molecules will move across a membrane from where they're more concentrated to where they're less concentrated if they can dissolve in that lipid bilayer core we talked about.
So solubility is still key.
Absolutely. The rate of this movement depends on a few things. One, the concentration gradient, how big the difference in concentration is. Bigger difference, faster movement. Two, that lipid-water partition coefficient, how much the drug prefers lipid over water. Higher coefficient, faster diffusion through the membrane. And three, the surface area of the membrane available. More area means more drug can cross at once.
Makes sense. High concentration pushing it across, liking lipids helps it get through the barrier, and more barrier means more crossing.
Precisely. And at steady state, when things balance out, for a drug that doesn't have a charged non-electrolyte, the concentration of the unbound drug will end up being the same on both sides of the membrane. It's just evening out.
Okay, following the flow from high to low. But you mentioned earlier that ionic compounds, drugs with a charge, behave differently at steady state.
That's a really crucial distinction. For ionic drugs, it's not just the concentration gradient. We also have to factor in the electrochemical gradient.
Electrochemical.
So charge matters too. Yes, it considers both the concentration and any electrical potential difference across the membrane. If the inside of a cell is negatively charged, for example, positive drug ions might be pulled in, even if their concentration isn't much lower inside. And critically, differences in pH across the membrane are huge for ionizable drugs, because pH determines how much of the drug is in its charged form versus its uncharged form on either side.
Ah, pH, right. Acidity and alkalinity.
Yeah.
How does that basic chemistry concept affect drug movement?
Well, a huge number of drugs are what we call weak acids or weak bases. This means in solution, they can exist in two forms that can switch back and forth. A non-ionized form, which is usually more lipid-soluble and crosses membranes easily, and an ionized form, which is charged, less lipid-soluble, and struggles to cross.
So uncharged slips through, charged gets stuck.
That's the essence of it. Think of common groups. Carboxylic acids often make a drug a weak acid. Amino groups often make it a weak base. Now, there's an exception. Quaternary amines always have a positive charge, regardless of pH. But for weak acids and bases, the key factor is the drug's pico.
PK, what does that tell us?
The pico has the specific pH value at which exactly half the drug molecules are ionized, charged, and half are non-ionized, uncharged. It's a measure of the drug's inherent strength as an acid or a base.
So it's like the 50-50 point for charge at a specific pH. And you mentioned the Henderson-Hasselbalch equation before. Is that how we figure out the balance at other pHs?
Exactly. The Henderson-Hasselbalch equation is the mathematical tool that connects the pH of the environment, the drug's specific pK, and the ratio of the charged versus uncharged forms. For a weak acid, let's call it HA, it can lose a proton to become A, the ionized form. For a weak base, B, it can gain a proton to become BH+, the ionized form. This equation lets us calculate precisely what proportion of the drug will be in its diffusible, non-ionized form in different body compartments, which can have very different pH values, like the stomach versus the intestine versus the blood.
Okay, so we can calculate the charge-uncharged ratio using the local pH and the drug's pK. How does this lead to that ion trapping phenomenon you mentioned, where drugs pile up on one side of a membrane?
Right, ion trapping. This is where it gets really interesting and clinically relevant. At steady state, remember, the non-ionized form equilibrates across the membrane. Its concentration becomes equal on both sides.
Yeah.
But if there's a pH difference across that membrane, the total drug concentration adding up both the ionized and non-ionized forms can become much, much higher on one side.
How does that work?
Take a weak acid drug. If it crosses into a compartment that's more basic, higher pH, that higher pH shift the equilibrium, causing more of the drug to become ionized, A form. Since that ionized form is trapped, it can't easily cross back through the lipid membrane. It accumulates in that more basic compartment. The total drug concentration ends up much higher there.
Wow.
And the opposite happens for weak bases. They get trapped and accumulate in more acidic compartments. This isn't just theory. It has huge implications. Look at figure 2.3 in GOODMAN and GILMAN's. It shows a weak acid moving between plasma, pH 7.4, and gastric juice, pH maybe 1.4. You see a massive accumulation in the plasma because it's much more ionized there and gets trapped.
So the drug gets physically stuck on one side just because the pH made it charged, and the charged form can't leave easily? That's fundamental. How do we actually use that in medicine?
We can definitely exploit it. A key example is influencing drug excretion by the kidneys. The pH of urine can vary quite a bit, maybe 4.5 to 8. So if someone overdoses on a weak acid drug like aspirin, we can make their urine more alkaline, maybe by giving sodium bicarbonate.
To trap the aspirin in the urine.
Exactly. More alkaline urine means more of the aspirin becomes ionized in the urine. Since the ionized form can't easily be reabsorbed back into the blood from the kidney tubules, it gets flushed out faster. We trap it in the urine for excretion.
And the reverse for weak bases. Make the urine acidic.
Correct. Acidify the urine to trap and excrete weak bases faster. This pH partitioning also explains things like why some antihistamines make you drowsy and others don't. Older ones like diphenhydramine are less ionized at body pH, so they cross the blood-brain barrier easily. Newer ones like loratadine are mostly ionized, so they stay out of the brain, less sedation. It even matters in things like urinary tract infections, where alkaline urine from bacteria can affect how well certain antibiotics work.
So pH isn't just some background value. It's a dynamic factor we can sometimes tweak to control drug movement and elimination. Okay, passive diffusion and pH covered. Now, the other main way drugs cross membranes, carrier-mediated transport. You mentioned facilitated diffusion and active transport.
Right. These involve specific proteins sitting in the membrane that act like helpers or pumps for moving molecules, including drugs. Facilitated diffusion uses a carrier protein, but, and this is key, it doesn't directly use cellular energy, like ATP.
So it's still passive, in a way?
It's still driven by the electrochemical gradient, moving the drug from high potential energy to low down the concentration or electrical hill. But it needs the carrier protein to make it happen. The protein binds the drug, changes shape, and lets it through. It's usually very selective for specific molecular structures. A good example is the OCT1 transporter, which helps move the nutrient thiamine, but also the diabetes drug metformin, into cells. These transporters belong to a big family called the FLC superfamily solute carriers.
Facilitated diffusion, needs a helper, still goes downhill. Now, active transport sounds like it takes more effort.
It absolutely does. Active transport is where the cell spends energy, usually ATP, to move molecules across membranes. And crucially, it can move substances against their electrochemical gradient, pushing them uphill, from low concentration to high.
Against the flow.
Exactly. Because it relies on specific carrier proteins binding the drug, it shows certain characteristics. It's saturable, there's a maximum rate, because there are only so many transporters. It's selective for what it transports. And it can be competitively inhibited if another molecule tries to use the same transporter. The classic example is the sodium-potassium pump, the Na plus K plus ADPase. It burns ATP to pump sodium out and potassium in, maintaining vital gradients. And the heart failure drug digoxin actually works, in part, by inhibiting this very pump.
Pushing against the gradient, needing energy, sounds like it can really build up concentration differences. What are some other key active transporters we should know about for drugs?
Well, the ABC family ATP binding cassette transporters are really critical. These are primary active transporters. They directly burn ATP to pump things, usually out of cells. A really important one is P-glycoprotein, or PGP, also called MDR1.
P-glycoprotein, I've heard of that. Multi-drug resistance.
That's the one. It's notorious. It has broad specificity that can pump out lots of different, often bulky, neutral, or positively charged compounds. Steroids, digoxin, many chemotherapy drugs. It plays a big role in limiting oral drug absorption by pumping drugs back into the gut lumen from intestinal cells.
So it reduces bioavailability?
It can, yes. It also helps keep drugs out of the brain at the blood-brain barrier. And fortunately, it's a major reason why cancer cells can become resistant to chemotherapy. They pump the drugs right back out.
Wow. So PGP is like a cellular bouncer, keeping things out or kicking them out. Good for protection, bad for drug delivery sometimes. What about that SLC superfamily you mentioned? Can they do active transport too?
Yes, they can through what's called secondary active transport.
Yeah.
These guys don't burn ATP directly. Instead, they harness the energy stored in existing ion gradients, usually the sodium gradient that the NOD plus K plus ATPase pump maintains.
Using one downhill flow to power an uphill one.
Precisely. It's like a water wheel using flowing water to lift something else. For example, the sodium-calcium exchanger, NCX, uses the energy of sodium flowing into the cell to pump calcium out against its gradient. This is actually part of how digoxin works too. By messing with the sodium gradient, it indirectly affects calcium levels. Other SLC transporters are symporters. They move the driving ion, like sodium and the drug, in the same direction. Think of the neurotransmitter transporters, D8, NET, SERT. They use the sodium gradient to pull dopamine, norepinephrine, or serotonin back into nerve cells. They're major targets for antidepressants and other CNS drugs. The SLC family is just massive and vital for drug transport all over the body, gut, liver, kidney.
Everywhere.
Yeah.
It's like this incredibly complex, coordinated dance of proteins and molecules across membranes using gradients and energy. Amazing. You also mentioned paracellular transport earlier, briefly, between cells.
Yeah, paracellular transport is movement between cells through the gaps, not through the cells themselves. In most blood vessels, like capillaries, the endothelial cells lining them have small gaps, allowing water and small solutes to pass relatively freely. Here, movement is often limited more by blood flow than the barrier itself. Think of edema and heart failure fluid leaking out through these gaps.
But not everywhere.
Not everywhere.
Yeah.
In the brain, capillaries, the blood-brain barrier, and some other epithelial tissues, the cells are sealed together by tight junctions. These really restrict paracellular movement, forcing most things to go through the cells using the transport mechanisms we've just discussed.
Tight junctions, another critical barrier, especially for the brain. Okay, we've covered the ways drugs get across membranes. Now let's zoom out a bit and look at the bigger picture after you actually take a drug. Absorption, bioavailability, and the different routes of administration.
Right. So absorption is the process of the drug moving from where you administered it, say, the gut if you took a pill into the central compartment, which we usually consider the bloodstream. For solid forms like tablets, the first step is always dissolution. It has to dissolve before it can be absorbed.
And then bioavailability. That term comes up a lot. What exactly is it measuring?
Bioavailability, symbol F, is super important. It's the fraction of the administered dose that actually reaches the systemic circulation unchanged. It's a number between 0 and 1 or 0% and 100%. When you take a drug orally, it faces many hurdles. It might not get fully absorbed from the gut. It might get broken down by enzymes in the gut wall. Then, after absorption, it goes straight to the liver via the portal vein before reaching the rest of the body. The liver is a major metabolism site. This breakdown in the gut and liver before the drug hits the main circulation is the first pass effect.
The liver gets first dibs on processing it.
Exactly. And that can significantly reduce the amount of active drug reaching the system. Contrast that with intravenous via injection. You put it directly into the bloodstream, it bypasses all gut absorption issues and the first pass effect. So IV bioavailability is, by definition, 100% or F1.
Makes sense. Phi avoids all those initial hurdles.
And this bioavailability concept also applies to prodrugs, those inactive drugs that need metabolism to become active. The extent they get converted also factors into the overall bioavailability of the active compound.
First pass effect. That really highlights why the route we choose matters so much. Table 2.1 in the source shows several routes. We mentioned IV 100% bioavailability, rapid, but maybe riskier.
Precisely. Phi gives immediate, predictable levels, great for emergencies, precise dosing. But the rapid high concentration can cause immediate side effects. And it needs expertise. Isn't suitable for all formulations.
Then there are injections under the skin, subcutaneous, SC, or into muscle, intramuscular IM. Still high bioavailability usually, but maybe slower absorption.
Generally, yes. SC and IM bypass the gut and first pass, but the drug has to diffuse from the injection site into capillaries. SC is usually slower because fat under the skin has less blood flow than muscle. IM can be faster, especially in well-perfused muscles like the deltoid. The rate depends on blood flow and the drug formulation. Depot injections are designed for very slow, sustained release from SC or IM sites over days, weeks, or months.
And the most common route, oral. Safest, most convenient, cheapest, usually. But bioavailability can be all over the place, right? Why such variability?
So many factors. The drug's own properties, solubility, permeability, the dosage form tablet, capsule, liquid. Did you take it with food? Other drugs. Then there's that first-pass metabolism in the gut wall and liver. Some drugs are just poorly absorbed. Some get destroyed by stomach acid or gut enzymes. Things like how fast your stomach empties matter. Even your gut microbiome, the bacteria living in your gut, can metabolize some drugs. And of course, did the patient actually take the pill as prescribed? Compliance is always a factor.
The gut microbiome, too, it really is a complex journey. You mentioned absorption from the gut is mostly passive diffusion. What determines how well that happens in the gut itself?
Several key things in the GI tract. Surface area is huge. The small intestine, with all its folds, villi and microvilli, has an enormous surface area compared to the stomach. That's why most drug absorption happens there, even if the pH isn't perfectly ideal for the drug's ionization state.
More space to absorb.
Exactly. Blood flow is also critical. Good blood flow whisks the absorbed drug away, maintaining the concentration gradient, pulling more drug across. The drug's physical state matters. Solutions absorb faster than solids that need dissolving. And its aqueous solubility needs to dissolve in the gut fluid first. And obviously, the drug concentration at the site drives diffusion. For pills, how fast they dissolve can be the rate-limiting step.
And pH still plays a role, even with the huge surface area of the intestine.
Oh, yes. The pH partition concept is still fundamental. The non-ionized lipophilic form crosses best. While the stomach is acidic, favoring non-ionized weak acids, the intestine's massive surface area usually wins out for both weak acids and bases, despite its slightly alkaline pH. Gastric emptying rate is also a big modulator. Speeding it up gets the drug to the intestine faster, potentially increasing absorption rate. Slowing it down, high-fat meals, certain conditions, delays absorption.
It's this dynamic interplay between the drug and the gut environment. We also have special pills, enteric coatings, and controlled release.
Right. Enteric coatings are designed to resist stomach acid and dissolve only in the more alkaline small intestine. This protects acid-sensitive drugs, prevents stomach irritation, or targets drug release lower down the GI tract.
Like for bowel conditions?
Exactly. Controlled release or extended release formulations are designed to release the drug slowly, over maybe 8 hours or more. The goal is less frequent dosing, which helps compliance, and more stable blood levels, avoiding the peaks and troughs you get with immediate release drugs. This can reduce side effects and keep the drug in the therapeutic window more consistently, often good for drugs with short half-lives.
Controlled release seems smart for maintaining steady levels. What about putting a tablet under the tongue sublingual? Does that bypass the gut entirely?
It does. Sublingual administration lets the drug dissolve and get absorbed directly into the rich blood supply under the tongue. The key advantage, the veins there drain directly into the superior vena cava, heading straight to the heart and systemic circulation. It completely bypasses the portal vein and that first-pass metabolism in the liver.
Ah, no first-pass hit.
Exactly. So bioavailability can be much higher and onset of action much faster. Nitroglycerin for angina is the classic example. Highly lipid-soluble, absorbed quickly, works fast because it avoids that first-pass breakdown.
Bypassing the liver makes a big difference for some drugs. Okay, oral injections. What about inhaling drugs? Pulmonary absorption.
Inhaling drugs, gases, or fine aerosols gives incredibly rapid access to the circulation. The lungs have a massive surface area and a very thin barrier between the air sacs and the blood. Plus, like sublingual, it bypasses hepatic first-pass metabolism.
Good for lung diseases.
Excellent for treating lung diseases directly, like asthma inhalers. Also used for systemic effects, like inhaled anesthetics, because absorption is so fast and efficient.
Makes sense. What about applying things to the skin? Creams, patches, topical, and transdermal?
Topical applications can be for local effects, like on the skin or mucous membranes, eyes, nose, throat, etc. Absorption through mucous membranes is generally pretty good because they're thin and well vascularized. Sometimes you can get systemic absorption even when you only intend a local effect. The eye is a common site for local delivery. Transdermal delivery uses the skin as a route for systemic absorption.
Like nicotine patches.
Exactly. Nicotine, scopolamine, fentanyl patches. Absorption depends on the drug's lipid solubility and the surface area. Healthy skin is a decent barrier, but absorption increases if the skin is damaged or hydrated, like under an occlusive dressing. Patches provide controlled, sustained release into the bloodstream over hours or days.
So skin can be a gateway, too, if the conditions are right. What about rectal administration? Suppositories?
Rectal administration has an interesting quirk. About half the blood draining the rectum bypasses the liver's portal circulation. So you get reduced first-pass metabolism compared to oral for that portion. However, absorption can be erratic, incomplete, and potentially irritating. But it's useful when oral isn't possible. Vomiting, unconsciousness, or sometimes for specific drugs like opioids in hospice.
And finally, you mentioned some really novel delivery methods emerging.
Yeah, there's some exciting stuff. Drug-eluting stents, placed in arteries, release medication right where it's needed to prevent reblockage. Microneedle patches use tiny needles to painlessly enhance drug delivery through the skin. And lots of work on biocompatible polymers, nanoparticles to target drugs specifically to certain tissues or cells, boosting effectiveness and cutting side effects.
Fascinating. So much technology goes into just getting the drug delivered effectively. Now, related to bioavailability is bioequivalence. What does that mean when we talk about generic drugs?
Okay, so two drug products are pharmaceutical equivalents if they have the same active ingredient, same strength, same dosage form, same route. Bioequivalence means these pharmaceutical equivalents also have essentially the same rate and extent of bioavailability. Basically, the generic performs in the body just like the brand name drug delivers the same amount of drug at the same speed.
So the generic should work the same way.
That's the goal and the regulatory requirement. It allows for safe substitution with cheaper generics, which is huge for access and cost. Pharmacists can usually substitute unless the doctor specifies otherwise.
Okay, bioequivalence ensures the generic is essentially interchangeable with the brand. Right, we've got the drug absorbed and into the bloodstream. Now, where does it go? Distribution time.
Once it's in the systemic circulation, the drug starts spreading out into the interstitial fluid, the fluid between cells, and potentially into the cells themselves. How fast and how far it spreads depends on, again, the drug's property, size, charge, lipid solubility, but also physiological factors. How much blood flows to different organs is huge. High-flow organs get the drug first.
Like liver, kidneys, brain.
Exactly. They see it quickly in the initial phase. Then, over minutes to hours, it distributes more slowly to the bulk of the body, mass, muscle, skin, fat, other organs. Capillary permeability matters too, how leaky the blood vessels are. It's easy to get out in most places, but much harder in the brain due to the blood-brain barrier. And finally, how much tissues bind the drug influences where it accumulates.
So blood flow delivers it, then it partitions based on permeability and binding. Does it just float freely in the blood, or does it bind to things there too, like plasma proteins?
Oh, definitely binds. Many drugs circulate largely bound to plasma proteins. Albumin is the main one, especially for acidic drugs. Alpha-1 acid glycoprotein binds many basic drugs. This binding is usually reversible. The drug hawks on and off.
And only the unbound drug is active, right?
Yeah, that's the key concept. Only the unbound or free fraction of the drug can leave the bloodstream, cross membranes, interact with receptors, get metabolized, or be filtered by the kidneys. The bound drug is like a temporary reservoir in the blood. The fraction bound depends on the drug concentration, its affinity for the protein, and how many binding sites are available.
Can this binding change, like with diseases?
Yes. Low albumin levels, like in liver disease or malnutrition, mean less binding, more free drug, potentially stronger effects, or faster clearance. Some inflammatory conditions increase alpha-1 acid glycoprotein, which can increase binding of basic drugs. Clinically, changes in binding are most concerning for drugs with a narrow therapeutic window that are highly cleared, where even transient changes in free concentration can matter. But mostly it affects how we interpret total drug level measurements, since assays usually measure both bound and free together.
So we need to remember it's the free concentration that drives the effects. What about binding within tissues? Does that happen too?
Absolutely. Many drugs accumulate in tissues at much higher concentrations than in the blood. This is often due to reversible binding to cellular components, proteins, phospholipids, even nuclear material. Tissues can act as significant reservoirs.
Like storing the drug up.
Exactly. This binding can prolong the drug's action as it slowly releases back into circulation. But it can also cause local toxicity if the drug accumulates too much in a sensitive tissue, like aminoglycosides in the kidney or inner ear. But sometimes intracellular accumulation is essential, like for antibiotics fighting infections inside cells. So tissue binding is another double-edged sword.
Storage units with potential benefits and risks? What about getting into really protected areas like the brain, the blood-brain barrier again?
Right, the BBB. Brain capillaries have those tight junctions we mentioned, blocking paracellular movement. Plus, glial cells wrap around the capillaries, adding another layer. So drugs generally have to get through the endothelial cells. Lipid solubility of the unbound, non-etherinized form is paramount here. The more lipid soluble, the better it crosses. The BBB also has active efflux transporters, like P-glycoprotein, that pump many drugs back out of the brain, further limiting entry.
So lipophilic and able to avoid the bouncers?
Pretty much. Though inflammation, like in meningitis, can make the BBB leakier, letting some drugs in that normally wouldn't cross. There's also a similar blood-CSF barrier at the choroid plexus.
Okay. What about other potential reservoirs? Bone, fat.
Yes, both can act as reservoirs.
Hmm.
Bone can accumulate certain drugs like tetracyclines or heavy metals like lead through binding to the bone mineral matrix. This could be a very long-term storage, slowly releasing toxins over years. Therapeutically, we use this for drugs like bisphosphonates. For osteoporosis, they target bone.
And fat.
Fat tissue is a major reservoir for highly lipid-soluble drugs. Fat content varies hugely between people. Because fat has low blood flow, drugs stored there release slowly. This can be good or bad prolonging effects, but also potentially acting as a stubborn reservoir for things like HIV or complicating dosing for lipophilic drugs.
So bone binds chemically, fat dissolves oily drugs. Both can hold on to things for a long time. You also mentioned redistribution can end a drug's effect. How does that work?
Redistribution is important for highly lipid-soluble drugs acting quickly on high blood flow organs, like the brain or heart, especially after rapid 5V injection or inhalation. Take thiopental, an IV anesthetic, it's very lipid-soluble, zips into the brain, high blood flow, causes anesthesia fast.
Right.
But then, as blood circulates, the drug starts moving into tissues with lower blood flow but larger volume or higher affinity, like muscle and especially fat. As the drug leaves the brain to go to these other tissues, the brain concentration falls below the anesthetic level and the patient wakes up.
Even though the drug hasn't been eliminated from the body yet?
Exactly. The effect stops because the drug moved away from the site of action, redistributed to other places. The overall elimination might still be slow, but the initial effect is terminated by this shift.
Fascinating. Redistribution, not elimination, ends the effect. Okay, one more distribution barrier. The placenta. Crucial for pregnancy.
Absolutely critical. The placenta is a selective barrier, but definitely not impermeable. Drug transfer depends on the usual factors: lipid solubility, protein binding, only unbound crosses, ionization state. Fetal blood is slightly more acidic than maternal blood, so weak bases might get ion trapped in the fetus.
Are there transporters too?
Yes. Efflux transporters like P-glycoprotein are present and try to pump drugs back to the mother, limiting fetal exposure. But there are also influx transporters. The bottom line is most drugs the mother takes will cross to the fetus to some extent. And since many drugs can harm the developing fetus, this is a huge area of concern and requires careful, evidence-based decisions. The FDA's PLL labeling is trying to provide better, more nuanced information than the old ABCDX categories.
A selective gateway, not a shield, really drives home the need for caution during pregnancy. Okay, we've done absorption and distribution. Next up, metabolism, how the body breaks drugs down.
Right, metabolism. So many drugs are lipophilic fat-loving, which helps them get absorbed and distributed, but that same property makes them hard to excrete in urine, which is mostly water. Metabolism is the process, primarily in the liver, of chemically changing these drugs, usually into more hydrophilic, water-soluble forms called metabolites.
Making them easier to pee out.
Essentially, yes. Making them more water-soluble makes them easier for the kidneys to handle. Metabolism also often, but not always, inactivates the drug, ending its pharmacological effect.
Okay, so what are the key principles of metabolism we need to grasp?
3 main things from a pharmacokinetic view. 1. First-order kinetics. Most drugs at normal doses. The rate of metabolism is proportional to the drug concentration. A constant fraction or percentage is eliminated per unit time.
Like 10% per hour, no matter how much is there.
Exactly. 2. Zero-order kinetics. For a few drugs, like ethanol or others at very high doses, the metabolic enzymes get saturated. They're working as fast as they can. Then a constant amount is eliminated per unit time, regardless of concentration. This can lead to drug accumulation if intake exceeds this maximum rate.
That sounds dangerous.
It can be. And 3, inducible enzymes. The main drug metabolizing enzymes, especially the cytochrome P450 family, or CYPs, can be induced their activity ramped up by exposure to certain drugs or chemicals. They also have broad specificity, handle many drugs, and show huge genetic variation between people. Drugs metabolized by the same enzyme can compete, affecting each other's breakdown, and a drug can even induce its own metabolism or that of other drugs.
First-order percentage, zero-order amount, and inducible inhibitable enzymes. What kinds of chemical changes actually happen during metabolism?
Generally, it's a 2-phase process, mostly in the liver. Phase 1 reactions usually involve oxidation, reduction, or hydrolysis. They often introduce or unmask a reactive chemical group on the drug, frequently using those CYP enzymes. Phase 2 reactions are conjugation reactions. Here, the drug or its phase 1 metabolite gets linked to another molecule like glucuronic acid, sulfate, glutathione, making it much more polar and water-soluble, ready for excretion. Then transporters often help move these conjugates out of the liver cell into bile or blood.
So phase 1 modifies it, phase 2 sticks something onto it to make it really water-soluble.
That's a good way to think about it. And remember, while the usual outcome is an inactive excretable metabolite, sometimes metabolism can create metabolites that are still active, maybe even more active, or sometimes toxic. And these enzyme systems also handle normal body compounds, like steroids. Liver's primary, but gut, kidneys, lungs also contribute. And disease, genetics, sex, ethnicity, other drugs, all can affect how efficiently these enzymes work. Understanding metabolism is crucial for avoiding drug interactions and moving towards personalized medicine.
So much variability. And you mentioned prodrugs again. How do they fit with metabolism?
Prodrugs are clever. They are inactive compounds that are designed to be metabolized into the active drug inside the body. Maybe the active drug is poorly absorbed, but the prodrug form absorbs well. Once inside, enzymes, often simple esterases, convert it to the active form. Enalapril is a classic example. It's inactive, gets absorbed, then hydrolyzed in the liver to active enalaprillate for treating high blood pressure. It's using the body's metabolism to activate the drug where needed.
Using metabolism to our advantage. And pharmacogenetics, how our genes affect drug response metabolism, seems like a prime area for that.
Absolutely central. Variations in genes coding for metabolizing enzymes like CYPs are a major reason why people respond differently to the same drug dose. Some people are rapid metabolizers due to their genes, clearing a drug quickly, maybe needing higher doses. Others are poor metabolizers, clearing it slowly, risking side effects at standard doses. Testing for these genetic variants is becoming more common to help tailor therapy precision medicine.
Tailoring drugs to our genes. Amazing. Okay, absorption, distribution, metabolism.
Yeah.
Done. Final step. Excretion. Getting the drug and its metabolites out.
Excretion, the final exit. Drugs and metabolites leave via several routes. The kidney is king. It's the most important organ for excreting water-soluble compounds into the urine. Unchanged drug excretion by the kidney is major for maybe 25–30% of drugs.
So what about other routes?
Feces are important, mainly for unabsorbed oral drugs or for drugs and metabolites excreted by the liver into the bile, which then enters the gut. Lungs, as we said, are key for volatile anesthetics. And then there are minor routes.
Like breast milk, that seems important.
Critically important, yes. Drugs excreted into breast milk can expose the nursing infant, who might be more vulnerable due to lower body mass and immature metabolism excretion systems. Unfortunately, good data is often lacking. LactMed is the best resource currently. The new FDA labeling rule, PLLR, aims to improve this. Milk is slightly more acidic than plasma, so basic drugs might concentrate a bit, acidic ones less so. Non-electrolytes generally reach similar concentrations as in plasma. Caution is always needed. Other minor routes include sweat, saliva, tears, usually tiny amounts, but sometimes useful for drug testing, like in hair.
So breast milk is a key consideration, and we need more data. Let's focus on the kidneys, the main excretory organ. How do they do it?
Three main processes in the kidney's functional units, the nephrons. First, glomerular filtration. Blood flows through the glomerulus, and small molecules, including unbound drug, get filtered out into the tubules, like coffee through a filter paper. Depends on kidney function, GFR, and free drug concentration.
Okay, filtration first.
Second, active tubular secretion. Specific transporters in the proximal tubule actively pump drugs from the blood into the tubule. There are separate systems for acids, OATs, and bases, OCTs. For many drugs like penicillin, this secretion is actually how most of the drug gets into the tubule, much more than filtration alone.
So they actively dump drugs into the urine.
They do. Third, passive tubular reabsorption. As the fluid moves down the tubule, water gets reabsorbed, concentrating the drug. If the drug is lipid-soluble and non-ionized, it can diffuse back across the tubule cells into the blood. This is where urine pH becomes critical again. If the urine pH makes a weak acid or base ionized, it gets trapped in the tubule, can't be reabsorbed, and gets excreted.
Filtration, secretion, reabsorption, and pH influences that last step. Can we mess with these processes pharmacologically?
Yes. We mentioned probenecid blocking penicillin secretion to prolong its effect. Probenecid competes for the OAT transporters. It also blocks urate reabsorption, helping treat gout. So we can use drug interactions at the transporter level to alter excretion.
Clever. What about special populations? Older adults, pregnancy, newborns, how's their kidney function?
Big differences. Older adults generally have declining kidney function, maybe 1% per year drop in GFR after age 40.
Yeah.
This slows excretion of renally cleared drugs, often needing dose adjustments. Pregnancy involves complex changes. Renal clearance might even increase for some drugs, but it's complex. Newborns have immature kidney function at birth, which matures over the first few months, so doses need careful adjustment.
Age and life stage definitely impact kidney excretion. What about the liver's role via bile? You mentioned enterohepatic recycling.
Right. The liver not only metabolizes, but also actively transports drugs and metabolites into the bile via transporters on the hepatocyte membrane facing the bile canalicula's. Bile flows into the gut. From there, the drug metabolite can either be eliminated in feces or reabsorbed back into the portal blood, returning to the liver. That's enterohepatic recycling.
It goes around again.
It can, yeah. Especially if gut bacteria can chop off conjugates, like glucuronides, releasing the original drug to be reabsorbed. This recycling can really prolong a drug's presence in the body. We can sometimes interrupt it with drugs that bind the stuff in the gut, like bile acid sequestrants.
Recycling loop. Okay, we've journeyed through ADME. Now let's tie it all together with clinical pharmacokinetics. How do we use all this in patient care?
Clinical pharmacokinetics connects everything we've discussed ADME to the drug's effects in a patient, usually by relating effects to the drug concentration in blood or plasma over time. The idea is that plasma concentration reflects concentration at the site of action.
So blood level correlates with effect, hopefully.
Generally, yes, whether that effect is therapeutic, adverse, or toxic. Clinical PK aims to quantify that dose-concentration effect relationship and provide a framework for choosing doses, interpreting drug levels, and adjusting regimens to get the best outcome for the patient, maximize benefit, minimize harm.
It's the practical application. What are the key parameters we use here?
4 are most fundamental for governing drug disposition. Bioavailability, F, volume of distribution, V, clearance, CL, and elimination half-life, T12. Of these, clearance is arguably the most important for designing long-term dosing.
Why clearance?
Because the goal is usually to maintain a steady-state concentration, CSS, within the therapeutic window. Steady state is achieved when the rate of drug elimination equals the rate of drug administration. The equation is dosing rate equals clearance x steady-state concentration, assuming F1 for now. So clearance dictates the dosing rate needed to hit a target CSS.
Clearance drives the maintenance dose, and steady state is that balance point.
Exactly. Input equals output. For most drugs at clinical doses, clearance is constant, first-order kinetics. Clearance itself is defined as the rate of elimination divided by the concentration. It represents the volume of blood or plasma completely cleared of drug per unit time, for example, ml mean. Total clearance is the sum of clearance by all eliminating organs, mainly liver and kidney. If those organs are impaired, clearance drops. We can calculate clearance from steady-state dosing or from the area under the concentration time curve, AUC, after a single dose.
Okay, clearance is how fast the body removes the drug. You also mentioned organ clearance and hepatic clearance specifics.
Right. Organ clearance depends on blood flow, Q, to the organ, and how efficiently the organ extracts the drug from the blood passing through the extraction ratio, E. Organ CL equals QAE. For drugs highly extracted by the liver, high E, clearance becomes limited mainly by liver blood flow. For poorly extracted drugs, clearance depends more on the liver's intrinsic metabolic capacity and the unbound drug fraction. Renal clearance is the net result of filtration, secretion, and reabsorption, all influenced by various factors we discussed.
So organ efficiency depends on blood delivery and extraction ability. Now, volume of distribution, V, again, you said it's conceptual, not literal.
Exactly. V relates the total amount of drug in the body to the concentration measured in the plasma. V equals amount concentration. It's the apparent volume the drug seems to occupy if it were uniformly distributed at the plasma concentration. For many drugs, V is huge, way bigger than total body water, because the drug leaves the plasma and distributes extensively into tissues, binding there. Digoxin, chloroquine have enormous V values.
So a big V means the drug isn't staying in the blood, it's out in the tissues.
Precisely. A small V means it's mostly retained in the bloodstream. V helps us understand this distribution pattern and is crucial for calculating loading doses.
Did we model this with one compartment or multi-compartment models?
Yes. The one-compartment model is a simplification treats the body as one unit. Instant distribution, often too simple. Multi-compartment models are more realistic. They have a central compartment, plasma, high-flow organs, and peripheral compartments, slower tissues like muscle, fat. Drugs move between these compartments at different rates, leading to more complex concentration time profiles, usually multi-exponential declines after an IV dose. These, the volume of distribution at steady state, is a key parameter from these models.
Multi-compartment is usually more realistic. Now, half-life, T12, how long it takes for the level to drop by half?
Half-life, T12, critical parameter. It tells us about the time course of elimination. It's mathematically related to both V and CL, T12V, V12V, ESCCL, VM. A longer half-life means slower elimination. It determines how long it takes to reach steady state, about 4 to 5 half-lives, and how long the drug persists after stopping. Half-life increases if clearance decreases or volume of distribution increases. Sometimes drugs show very long terminal half-lives due to slow release from deep tissue compartments.
So half-life depends on both distribution volume and clearance rate. What about absorption rate and extent, again, bioavailability? How do they fit into the clinical picture?
Bioavailability F, the extent, tells us what fraction of the dose gets in. We must include F in our dosing calculations, especially for oral drugs. Dosing rate equals CL, S. The rate of absorption affects how quickly peak levels are reached and how much fluctuation occurs between doses. Faster absorption gives higher peaks sooner. Slower, controlled release absorption gives lower peaks later, but more sustained levels, often minimizing side effects and improving efficacy by staying within the therapeutic window better.
Rate affects the shape of the curve, extent affects the overall exposure. Got it. Now, what about when things get weird? Nonlinear pharmacokinetics.
Right. Nonlinearity happens when our usual assumptions break down, usually because a process gets saturated. Like protein binding, if sites fill up, free fraction increases non-proportionally. Or, more commonly, saturable elimination metabolism or transport reaches its maximum capacity, Vmax.
Like the zero-order kinetics we mentioned.
Exactly. When drug concentration exceeds the system's capacity, often represented by CAR-MAM, the concentration at half maximal rate, elimination rate becomes constant, not proportional to concentration. This means small dose increases can cause huge jumps in steady-state levels. First-pass metabolism might also become less effective, increasing bioavailability unpredictably. Half-life is no longer constant. It increases with concentration. Phenytoin is the classic example. Saturation happens right in the therapeutic range, making dosing very tricky. Careful monitoring is essential for such drugs.
Saturation throws off all the usual predictions. Okay, brings us to the payoff. Designing and optimizing dosage regimens.
This is the ultimate goal. We want to take drug levels within the therapeutic window that range between the minimum effective concentration, MEC, and the minimum toxic concentration. We need enough drug to work, but not so much it causes unacceptable harm.
Finding that sweet spot.
Exactly. For long-term therapy, we design a maintenance dose regimen, the right dose given at the right interval, to keep the steady-state concentration within that window. We use the relationship, dosing rate, target CSS, TSSF. We need estimate to the target level, the patient's clearance, and bioavailability.
And the dosing interval matters too.
Absolutely. Dosing too infrequently lets levels fall too low between doses. Too frequently might be inconvenient or cause levels to peak too high. The interval is often guided by the half-life. Dosing every half-life gives about a two-fold fluctuation, often acceptable. For drugs with narrow windows, we might need to calculate expected peak and trough levels more carefully to ensure they stay within range.
Maintenance dose keeps it there. What about getting there fast? Loading doses.
When we need an immediate effect, especially with long half-life drugs, waiting 4 to 5 half-lives for steady state isn't feasible. A loading dose is a larger initial dose calculated to quickly achieve the target concentration. Loading dose A, target CP, AUA, SAAS, it fills up the volume of distribution quickly. Lidocaine for arrhythmias is a good example.
But loading doses have downsides.
They can. Giving a large dose quickly risks overshoot hitting toxic levels, especially if the patient is sensitive or clears the drug slowly. Rapid high levels can also cause acute toxicity. So loading doses are often given cautiously, maybe split into smaller parts or infused slowly.
Get there fast, but be careful not to overshoot. Finally, therapeutic drug monitoring. TDM measuring levels. How does that help?
TDM is invaluable, especially for narrow therapeutic index drugs or complex patients. Measuring a patient's actual steady-state drug level allows us to refine our estimate of their individual clearance, adjusted for bioavailability. CLF dosing rate measured CSS. We can then use this personalized CLF value to adjust their maintenance dose much more accurately to hit the desired target.
Tailoring the dose based on measured levels.
Precisely. Timing of the sample is key. Usually trough levels, just before the next dose, are best for adjusting maintenance doses to avoid accumulation. Peak levels might help assess efficacy or toxicity concerns, and you need to wait until steady state, or close to it, maybe after 2 half-lives, before the measurement is truly meaningful for dose adjustments.
So TDM provides direct feedback for personalization. Wow, we have really gone deep into the journey of a drug today.
We really have. From absorption across membranes, influenced by physics and chemistry, through distribution determined by blood flow and tissue binding, transformation by metabolism, and finally elimination via kidneys, liver, and other routes, ADME. Understanding these processes, and the parameters like clearance, volume, half-life, bioavailability, it's the foundation for using drugs effectively and safely.
And it's definitely not simple or uniform. Individual factors, genes, diseases, age, interactions, they all make pharmacokinetics incredibly personalized. TDM really underscores that need for tailoring therapy.
Absolutely. So now that you've got this deeper understanding, this more intricate picture of the dance between a drug and the body, maybe think about how this changes how you view medications, prescribed ones, over-the-counter ones.
Yeah.
And appreciate the ongoing science trying to optimize this dance, better drug delivery, personalized medicine based on pharmacogenetics. It's all aimed at making these interactions work better for each of us. Hopefully this deep dive gives you a solid base to explore even more about specific drugs or conditions that interest you, armed with these core pharmacokinetic principles.